Hi my scholars, in today's video we shall be looking at the bones of the forearm. And we've gone a bit far in this osteology, and if you have not watched the previous videos, do well to watch that. Alright, so let's go into it. So today we'll be looking at the gross anatomy of the radius and the ulna. First, the radius and ulna are the bones of the forearm. And these bones of the forearm, one is lying on the medial side and one is lying on the lateral side. So the medial bone of the forearm is called the ulna, while the lateral bone of the forearm, this bone right here, is called the radius. Take a look at the orientation. The head of the radius is directed upwards, the head of the ulna is directed downward. But one thing is common. Both the styloid process of the ulna and the styloid process of the radius are directed downwards. Okay, so this is the styloid process of ulna, and this right here is the styloid process of radius. This is the head of the radius, this is the head of the ulna. So the head of the ulna is directed downwards, while the head of the radius is directed upwards. Head of radius. Good. Both bones are united by a membrane. See this membrane right here. This membrane is called the interosseous membrane. The interosseous membrane. Inter means between. Osseous means bone. So the interosseous membrane is what connects or separates rather the radius from the ulna. And the radius, the ulna, together with the adjoining interosseous membrane actually divided the forearm into two compartments. So the anterior compartment or the flexor compartment and the posterior compartment or the extensor compartment. What are the basic features that this bone possesses? So we've said that the radius has an upper end and a lower end separated by a shaft. So the shaft is this long, bulging, extending part right here. That is the shaft. Okay, so this place, this structure right here is called the radial tuberosity. So it is a roughened bony elevation at the upper end of the radius, and it separates the upper end of the radius from the shaft. So this whole region right here is the shaft of the radius. This small constricted portion, this constricted portion that is below the head of the radius is called the neck of radius. Neck of radius. So the radius has a head, a neck, and the radial tuberosity at the upper part. So the mid part is known as the shaft of the radius, and at the lower part, the shaft expanded. The shaft of the radius expanded at the distal aspect. And this distal expansion has a significance. And that is because right here, the radius has three borders at the upper part. So the upper two-thirds of the radius has three borders. And these borders are anterior border, posterior border, and this sharp border right here that faces the ulna is called the medial border. But the expansion of the distal shaft of the radius made the radius at its distal end, when you take a cross section, to have 5 surfaces and so many borders. Okay, so at the upper end you are going to have 3 surfaces, and these 3 surfaces are lateral surface, anterior surface, and the last surface is the posterior surface. So at the upper part of the shaft of radius, you have 3 borders and 3 surfaces. So, but at the distal end of the shaft of radius, instead of having 3 surfaces, you are going to have 5 surfaces because of this expansion. So right here, you are going to have, at the distal end, you are going to have an anterior surface, a posterior surface, a medial surface, a lateral surface, and the surface underneath, known as the inferior surface. Okay, so the lateral surface projects downwards away to form the styloid process of the radius. The medial surface presents a notch. This notch right here is called the radial notch. So the radial notch is where the head of the ulna articulates the radius. And this joint formed right here is called the distal radio-ulnar joint. So the distal radio-ulnar joint is formed right here. Okay, while at this upper part, we are going to have the ulnar notch. This notch right here is the ulnar notch, or the notch of the ulna. And the notch of the ulna articulates to the circumference of the head of radius to form a joint right here. And this joint is known as the proximal radio-ulnar joint, or the superior radio-ulnar joint. This one is the distal radio-ulnar joint. Okay, so both bones are in contact above and below, but they are separated along the middle part. So take note of that. Alright, so for the ulna also has three borders. It also has an anterior border, a posterior border, and a medial border. And three surfaces: anterior surface, posterior surface, and the medial surface. So the radius has anterior surface, posterior surface, and the lateral surface. While here you have a medial surface. It's important to take note of that. So, and I'll use this opportunity to tell you about their ossification. So they have three borders, three surfaces at most lengths of their shaft. It's the same way they also have three ossification centers. When you look at the ossification of these two bones, they ossify from one primary ossification center and two secondary ossification centers. The one primary ossification centers for each of them will appear in the middle of the shaft. So this right here. While the two secondary ossification centers, one will appear for the upper end and one will appear for the lower end. Okay, very important to take note of that. So the radius has one primary ossification center and two secondary ossification centers. That is three. The ulna has one primary ossification center that appears in the middle of the shaft and two secondary ossification centers, one for the lower end and one for the upper end of this bone. Okay. So what are the features that you need to take note of when you are discussing the ulna? Maybe in your exams, you must mention that the ulna has processes. This process right here that receives the attachment of the triceps breaker is called the olecranon process. And when we discuss the humerus, we see that the humerus has a fossa called the olecranon fossa at the distal shaft of the humerus, at the lower end. So that fossa accommodates the olecranon process during extension or in full extension. It's going to accommodate the olecranon process. And that is why you don't extend beyond that lock. So the olecranon process locks into the olecranon fossa and extension is limited. Okay, further forceful movement is going to cause fracture of the olecranon process. And this process receives the insertion of the triceps breaker. And we have this process right here. It's called the coronoid process. So the coronoid process is a bracket-like projection. Bracket-like projection. So this coronoid process, okay, is going to fit into the coronoid fossa during flexion. So the coronoid fossa of the humerus accommodate the coronoid process of the ulna during flexion. And once it locks into the coronoid process, into the coronoid fossa of the humerus, flexion is completed, okay, and it's limited at that point. Alright, so both bones have styloid processes, both bones possess notches. This is the notch of the radius, and this is the notch of the ulna. Both bones possess head. Both bones, okay, also possess shafts, and both bones possess upper end and lower end. These are the various similarities you must know. Both bones ossify from one primary ossification centers each, and 2 secondary ossification centers each for the upper end and for the lower end. All right. So coming this way, this is the posterior aspect of these two bones. What are the things we are going to see right here? So of course, this is the styloid process. This is the shaft of the ulna, okay, and this is coronoid process. This right here is the cranium, and this right here is the neck of radius. This is the head of radius. This is the radial tuberosity. Now the radius presents a line, and this line extends from the radial tuberosity. And these lines are two. So we have what is called the anterior oblique line of the radius. And we have another line called the posterior oblique line of the radius. So this line we are seeing on the posterior aspect is going to be the posterior oblique line. So it actually extends from the radial tuberosity and fans out downwards. That is the posterior oblique line. So guys, up next we are going to look at the muscle attachments of the radius and the ulna. But before that, let us look at some clinical correlates. So these bones can fracture. In fact, in most old people, okay, the radius is very susceptible to fracture. And because, why? This is because the radius is the weight-bearing bone of the forearm. When we look at the line of transmission of forces, the radius receives the force, okay, from the carpal bones, and the radius can easily fracture because of that. It is the major weight-bearing bone. In fact, weight from the ulna is transmitted onto the radius, and the radius pushes it up to the humerus when we are doing lifting, grasping of objects, and many other activities. So how does that occur? So in the clinical correlates, we can have fracture of the radius. Fracture of radius. And the fracture of the radius can occur at different points. So we can have fracture of the shaft, of radius. There's also fracture of the distal end. Fracture of distal end, or the fracture of the lower end of the radius. This is important to us because when the distal end of the radius fractures, somehow the distal 1/3 of the shaft, just above the distal 1/3 of the shaft. So you have a fracture right here, above the distal 1/3 of the shaft. So if this fractures, okay, the distal end of the radius moves backwards and upward, and that fracture is called a Colle's fracture. Colle's fracture. So in Colle's fracture, there's fracture of the shaft of the radius, and the distal end, or the segment that is distant to the site of fracture, it becomes oriented backwards and upwards. We call that Colle's fracture. But what if this fracture occurs at the same point, okay, or a bit lower down here, and rather instead of this, the distal segment to be directed backward and upwards, it now becomes directed forwards and downwards. We have another name for that. That is called the reverse Colle's fracture. And the reverse Colle's fracture is called the Smith's fracture. Smith's fracture. So these projections right here, called the styloid processes, can also fracture. Fracture of the styloid process of radius is another. So fracture of styloid process of radius. And then another we have is this fracture of the styloid process of the ulna. It can also fracture. Fracture of styloid process of ulna. So the fracture of the styloid process of the radius has a clinical term. because it was first described by Cauffer. So, and it's called the Cauffer'S fracture. So the Cauffer'S fracture is the fracture of the styloid process of radius. Other important clinical correlates include the green stick fracture, the green stick fracture of the ulna and the radius. Okay, that's another clinical correlate you can add there. And the anterior aspect of the distal shaft of the radius can bow beyond normal. So the increase in the bowing of the anterior aspect of the distal shaft of radius is a deformity, is a congenital deformity. And that deformity is called the mid-lungs deformity. So we have the mid-lungs deformity. Lungs deformity. Alright, still on the styloid process of radius. Okay, we can actually palpate a pulse, the pulsation of an artery, known as the radial artery. So you can palpate the radial artery against, okay, the distal shaft of the radius, close to the styloid process. That pulsation you feel there is the radial artery, pulsation of the radial artery, and it's very much important in clinical practice. That is another clinical correlate. So the next clinical correlate we need to take a look at is the fracture of the ulna. If there's fracture of the styloid process of the ulna, okay, this fracture can cause changes in the orientation of the articular surfaces at the distal end of the ulna, and that is very, very important. Okay, then some tendons are passing at the inferior surface of the radius and ulna. The extensor tendons, basically, extensor carpi radialis longus, extensor carpi radialis brevis, extensor indicis, extensor digitorum, those muscles, even extensor digiti minimi, their tendons are actually traversing the inferior aspect of these two bones. They are grooving it rather. And these tendons can get dislodged, okay, if what is holding them in place called the retinaculum or the deep fascia that is modified, which is holding them in place, is actually scattered, maybe by trauma or poor surgical repair when there is a fracture around the region, and so many other things. Okay, there could also be dislocation of these articular surfaces because it's going to articulate with the carpal bone, so it can actually be dislocated. These are the various clinical correlates that I want us to remember when we discuss the gross anatomy of the radius and the ulna. Alright, one more feature before the end of this video. Okay, the inferior aspects of the radius. The radius at the distal aspect has 5 surfaces. I'm interested in the posterior surface because you can be tested in your MCQ. The posterior surface of the distal shaft of the radius, posterior surface of the lower end of the radius presents a tubercle. Tubercle is a bony prominence. That tubercle is called the dorsal tubercle of Lister. So you can call it the dorsal tubercle, or you call it the Lister's tubercle. And this is because it was first reported by Joseph Lister. So it's called the Lister's tubercle. Lord Joseph Lister. He was an anatomist. So many scholars have been able to give in-depth explanation of the basic features of the radius and the ulna, and we've also talked about their definition and what is joining them together. Both bones possess nutrient foramina, the nutrient foramen for the radius, the nutrient foramen for the ulna, and that is how they receive their blood supply. Do well to subscribe to this channel for further videos. Thank you.